Welcome to the October Dementia Care Aware monthly webinar. Today's topic is behavioral symptoms in dementia part 2 with the focus on behavioral modifications. Next slide, please. My name is Josette Rivera. I'm a geriatrician at the University of California, San Francisco, and the education lead for Dementia Care Aware. And I am very excited and happy to present the featured key speaker today, Michelle Panlilio, a nurse practitioner and national lead dementia care specialist of UCLA's Alzheimer's and Dementia Care program. Next slide, please. We have no financial disclosures to share. Next slide. And before we kick off, I wanted to share some brief housekeeping tips. We will leave time at the end of the presentation for Q&A. Throughout the webinar, you can feel free to put questions in the Q&A or chat functions. If possible, we'll try to answer them in real time, and if not, we will try our best to get to them at the end. We will share instructions for claiming continuing education credit at the end of this webinar and also via email within 2 days. And you will also receive a recording of the webinar via email within 2 days. You can also access the webinar slides and recording from the Dementia Care Aware website and YouTube channel. Next slide, please. Before we begin, as we start every webinar, I wanted to remind us of all the offerings of the Dementia Care Aware program, which include a warm line. The warm line is specifically for providers, not for patients or the community. And it's a provider support and consultation service that connects primary care teams with Dementia Care Aware experts. There are also a whole suite of trainings online, as well as our monthly webinars such as this and podcast. In addition, there's interactive case conferences sponsored by our amazing partners at UCLA and UC Irvine. And finally, some very robust practice change support programs by UCLA's Alzheimer's and Dementia Care program, as well as with our Alzheimer's Association partner. Next slide, please. So again, I just wanted to remind us of the suite of online trainings for which you can receive free CE, and they are all available from the Dementia Care Aware website. Next slide, please. All of the online trainings center around the cognitive health assessment, which is a very brief screening designed for busy primary care practices. In some, it's 3 parts: taking a brief patient history, using cognitive and functional screening tools, and then finally documenting care partner information if available. And the idea is that this is an assessment for which we should screen patients over 65 annually, and obviously those who don't already have a diagnosis of dementia. And early detection allows you to start a brain health plan at the earliest signs and symptoms. Next slide, please. So with that, I will turn it over to Michelle. Thank you, Michelle.
Thank you so much, Dr. Rivera. Hi, everyone. I'm Michelle Panlilio. I'm a geriatric nurse practitioner, and I'm the national lead dementia care specialist for the ADC dissemination program. Thanks so much for having me again here. So part 1 of our webinar actually aired on August 29. And the focus of that webinar was on assessment of behavioral issues in dementia. For those of you who were not present for that webinar, please visit the Dementia Care Aware website where you can watch the video. For those of you who were here for that first part, you might notice that I left some of the slides from the first webinar on this current slide deck. And I left them in case some of you would like to review the behaviors. So for this webinar, we're going to discuss behavioral modifications for behavioral problems with persons with dementia. And we're also briefly going to revisit the Neuropsychiatric Inventory Questionnaire, the NPIQ, which is a tool, and how you can use it to evaluate behavioral modifications with your patients. And lastly, we're going to talk about free resources for providers and their healthcare teams. So a brief review of the first webinar. These are some of the symptoms that we discussed during the first webinar. The NPIQ, again, is a tool that measures 12 possible domains of behavioral problems that we might see in our patients. The NPIQ, it's used for clinicians, or clinicians can use it to evaluate the presence of these behaviors. Now, in the UCLA ADC program, we generally use it during the initial and annual assessments. We compare the behaviors through the years to see if there are any trends in the severity of the behaviors and also the distress on the caregivers. We also like to use it if we are actively managing behavioral symptoms with families. So quick review, the tool itself is actually completed by the family or the caregiver based on symptoms that they've seen or observed in the past month. The severity reflects the patient's symptoms, and the distress levels are the caregiver's distress levels on the behaviors. So what exactly are behavioral modifications? So behavioral modifications are going to be the main focus of today's webinar. Behavioral modifications are changes in the caregiver's approach aimed at reducing or improving behavioral problems. So if a patient is exhibiting acute behaviors, meaning they develop these symptoms quite suddenly, make sure that you rule out any reversible conditions first. Now, in my practice, generally the most common culprits for acute symptoms are urinary tract infections, constipation, dehydration, and sometimes upper respiratory infections. So make sure that you rule those out first. Now, the approach, whenever you're approaching caregivers, make sure that you're using a patient-centered approach, in that all patients are different and all caregivers are different. So some behavioral modifications are not going to work for all other patients or caregivers. When you are addressing behavioral modifications with caregivers, I think it's important that you are realistic with the caregiver, have this discussion with the caregiver, and be realistic about the goals as well as the time frame. And by that, I mean that, there are going to be some problems that are going to take longer to improve because they're just more stubborn problems. And not all behaviors are going to resolve. Whenever I'm working with caregivers, I try to encourage them to use, when we're talking about how they're doing and how the behaviors are doing, I ask them, when I call you, tell me if the symptoms are better, same, or worse, and then we'll get started from there. I thought it would be helpful to give you an example of one of our patients in the ADC program. And this is actually a patient of mine that I recently met. Mrs. Johnson is a 90-year-old female with late onset Alzheimer's disease, and she was diagnosed in 2019. She lives at home with her husband, who has chronic medical issues, and he has a private caregiver. Their daughter, Melissa, lives 1 hour away, and Melissa comes in weekly to coordinate her parents' care. Mrs. Johnson is relatively healthy for somebody her age. She has hypertension, moderate depression, hyperlipidemia, and hypothyroidism. Socially, she and her husband live in a single family home, which they've owned for over 60 years. And that's actually where they raised Melissa, their daughter. She is a retired musician, and she's performed worldwide. She has a graduate degree in music, no alcohol or drug use, and financially they are stable. She has long-term care insurance with lifetime benefit. So she planned pretty well for herself and her husband. As far as her physical exam, it's limited because she actually she didn't let me do a whole lot. So Mrs. Johnson, she's an elderly female, she's pretty thin, casually groomed in jeans and a sweater. She is ambulating without any help, steady gait. What was noticeable about Mrs. Johnson was that she was very distressed at the time of the visit, and this is our initial visit. She was noted to be argumentative, not just with her daughter, but also the nursing staff. She was visibly upset, noted to be physically threatening towards her daughter. She refused a physical exam from me, as well as any cognitive exams. In the clinic, it got to a point where the arguing was so bad and so loud between my patient and her daughter that the clinic staff actually alerted the security. So this is how Melissa completed the initial NPIQ tool. The severity score was 17, and her distress levels about her mom's behaviors was pretty high. It was at 24. And so overall, these are the symptoms that the daughter had mentioned to me during the appointment. She thinks her husband is having an affair with a caregiver. She is verbally aggressive, verbally and physically aggressive towards her family, as well as their caregiver. And when she does, that's when she normally will prevent the caregiver from taking care of her husband. Mrs. Johnson is also reported to, she sundowns. And when she does, she goes out of the house. She leaves the house to look for her parents, who have obviously passed on. There was one time that she wandered into traffic and she was unable to find her way home. Fortunately, they had a neighbor who saw her and actually brought her back to the family house. Again, she's noted to be cursing and yelling at the caregiver and the family. And, this is very upsetting for Melissa because she told me that her mother never used to curse or yell at anyone. There's also been a 10-pound weight loss in the past 3 months. So she's actually down to 89 pounds. So quick review of delusional behavior. Mrs. Johnson, certainly she has some delusional behavior. She thinks her husband is having an affair with a caregiver and reacts by preventing the care from taking care of her husband. I think from my practice, this is probably one of the more common delusions that I encounter. So what do you do when you have a delusional patient? It's important to stay calm, and this is not always easy. One of the recommendations that we make is to change the patient's environment. Take them out for a walk or some kind of an activity, and remove them from the environment that is triggering the delusions. So sometime during the appointment, Mrs. Johnson actually became very agitated with me when I was asking, tough questions. And so I shifted and I distracted her from the nature of the appointment I looked her up on YouTube because I knew that she was on there. And so I looked her up on YouTube, and then I showed her a video and I asked her if it was her that was performing in the video, which it was. And Mrs. Johnson was so happy and she was pretty shocked to see herself on the screen. Now, in some situations, I try to find something that they might be interested in that I can relate to. So if they are a parent, if I know that they have kids, then I'll ask them about their kids and I'll share, that I have kids of my own. Or if they like dogs, I might show them a picture of my own dog so that we can find some common ground. Again, it's all about distraction. Hallucinations occur when the patient sees or hear things that are not really present. So what do you do? First thing, identify the triggers. because there is usually a trigger when somebody is having hallucinations. So are they, evaluate if the patient is tired, or are they hungry? Are they not wearing their glasses or their hearing aids? Are the lights playing any tricks on them? And so use bright lights after sundown and make sure that items are not casting shadows in the room. And make sure that at this time, make sure that they have their hearing aids and their glasses. If the patient is talking to the TV, or they believe that the characters on the television are speaking to them, teach the caregivers, please turn off the TV. Make sure that they are not watching the news at night, in particular, because they're not able to tell what is real and what is not. So stick to watching things like musicals, nature shows, or animal shows. Let's not forget that Mrs. Johnson had a lot of agitated behaviors towards a caregiver. So she was verbally aggressive and threatening, and again, also physically aggressive towards the husband's caregiver. One thing to consider is that Mrs. Johnson, she's very healthy. She's physically healthy. She's ambulatory. So someone like her can still, or has the ability to inflict a lot of harm on the caregivers if she really wanted to. So the trigger in this particular situation with Mrs. Johnson was the caregiver being in the household and giving care to the husband. So what is she supposed to do when they're in the home setting? Instruct the caregivers to always keep calm. There is this behavior that we encourage our caregivers to do, which is actually called mirroring. And mirroring is basically, when you as a caregiver are coming into a situation or a patient, taking care of any kind of patient, make sure that you're always calm and collected. And you might need to take a few minutes before you have an interaction with that patient. In the clinic, I generally always keep a low tone of voice with an agitated patient, and sometimes it's almost a monotone. I do check myself emotionally before going in to see a patient, making sure that if I'm tired, I'm not projecting that kind of emotion when I see that patient. But particularly if the patient is agitated, then I will definitely spend a couple of minutes and just try to calm myself and get ready for that visit. One of the things that I do teach caregivers is not to engage the patient in any arguments, because engaging them in a back and forth argument is just not going to solve anything. Now, for Mrs. Johnson, much of my initial interventions was to actually educate the daughter and why she shouldn't be engaging her mother into arguments, because her mother is so educated and she's really smart. Melissa still thought that she could reason and see through her rationale, but obviously that was not working well. So in this next slide, I added one of the many caregiver videos in the UCLA ADC program website. These are short slides and they're anywhere from 4 to 5 minutes long, and they typically will target one behavioral problem per video. So they're available in several languages and they're free for anyone to use and share. You can use the QR codes in the latter part of these slides on your phone or go into the UCLA ADC program website. So the videos, they typically start off with scenarios of what happens with our patients and caregivers. And the videos, they're going to provide brief explanations by our faculty on why these behaviors are happening. And the last minute of each video typically will give a demonstration of behavioral interventions that can be done by families and caregivers to get a more favorable outcome.
hired a caregiver to stay with my mom while I'm at work. My mother becomes mean and aggressive towards the caregiver when she tries to get her ready in the morning. My mom yells at her to get out and may even try to slap her away. It is a daily struggle and the caregiver is ready to quit. I can't be with my mom every single minute and I don't know what to do. Tina, it's time to wake up. Let's go to the bathroom to clean up. Let's get out of bed.
I don't want to get out of bed. I don't want to get ready.
Come on, not again. Please don't give me a hard time. Your bed is wet. You need to wash up. It's 9 a.m. It's time for your breakfast and medication.
I don't feel like it. I don't need your help.
Stop it and calm down.
Don't touch me. How dare you telling me what to do? I don't need your help.
I am just doing my job. Let's get ready for the day.
I don't need you. Get out of my house and leave me alone.
People can become aggressive for many reasons. It may be an expression of pain, fear, frustration, depression, or anger. People with dementia may not understand what you're asking them to do and become frustrated. They may genuinely not understand what they need to do something, like take a pill or bathe. Aggression usually isn't personal, although it certainly feels that way. Reacting to aggression with anger, shock, or yelling only escalates the situation. First, de-escalate the situation by behaving calmly. Identify yourself if you need to. It's possible that your loved one does not recognize you. Speak to the emotions that might underlie the aggression. It could be fear, pain, or frustration. Use distraction, encouragement, reassurance, and try to be flexible if someone is being uncooperative and angry.
Good morning, Tina. This is Jane, your caregiver. Your breakfast is ready. Would you like to eat downstairs?
I like my bed. I want to stay here. You can bring my breakfast here in bed.
I can do that. I see that your bed is wet though. I would like to make your bed so you can rest comfortably. Meanwhile, would you like to eat at the dining table?
No, I want to have my food here in bed.
Okay, how about if you eat right over here, just while I make your bed?
Okay, fine.
Here are a few tips on how to respond to aggressive language and behavior. Keep it simple, one instruction or question at a time. Don't escalate tensions by being bossy or yelling. Instead, use a calming tone of voice, but do not be condescending. Provide reassurance. Let your loved one know you're there for support. Keep your body language positive and use calming gestures and gentle touch. Give ample time. Redirect or give ample time and space for cooling off and reattempt later. Remain safe. Back away slowly if the behavior is threatening. Remove or lock away all weapons like guns and knives. Call 911 if physical aggression cannot be redirected and your loved one is a danger to themselves and or others.
Okay, back to behavioral disturbances. So I had previously mentioned this during the first webinar. Depressive symptoms in patients with dementia it can be challenging to evaluate, as the symptoms are not always so obvious. So families might often report irritability as one of the main symptoms of depression. What we do know is that if we don't treat the depression in patients with dementia, they often decline faster cognitively. So prior to starting a patient on an antidepressant, encourage them to basically get out of the house, because these patients should have daily physical exercise, and they don't need to join the gym. They don't need to join the gym or start lifting weights. Walking counts. Walking is great exercise at least 30 minutes per day. Ideally, this should be done outside, but if they prefer to stay out of the sun, then they can always walk through the malls. Social activities such as adult daycare or senior centers with their caregivers is also a great way of getting the physical and social stimulation that these patients need. Anxiety can be seen in several different ways in persons with dementia, whether they're sundowning or pacing, if they're unable to sit still, or if they are wandering. Often the source of anxiety is because they are bored and have a lot of unspent energy. So what can families do to prevent anxiety in their loved ones? Well, if looking at the slide, you might see that some of these recommendations are similar to preventing depression. So families need to ensure that their loved one is getting, adequate physical exercise and social stimulation from activities. Additionally, ask the caregivers to rule out any unmet needs like pain, hunger, fatigue. And a lot of times, the caregivers and families are actually able to predict these behaviors after being with a patient for a while. I also wanted to briefly mention that if the patient, like Mrs. Johnson, if the patient has the physical ability to leave the house alone, please make sure that they have ID bracelets at the very least. And if the patient is young and they're very mobile, it probably would be more appropriate to recommend GPS trackers. Some patients may have apathetic behaviors, which is the lack of interest in their usual activities or previous interests. Now, this can be very distressing and hurtful to families, particularly if it's a big change in their loved one's personality. Regarding apathy, I find that the most important intervention for this behavior is really to educate your caregivers. Apathy is often challenging to treat. And so I often provide education to the families to try to manage their expectations. So for example, if the family is reporting that dad doesn't want to shower anymore, I will encourage the families to become more engaged and involved in the activity. So I might say something like, it's no longer okay to expect your dad to shower properly on his own. And you can start by seeing if giving dad step-by-step directions is helpful, and make sure that you're patient and that you are allowing for plenty of time to complete the activity. Elation or euphoria is when the patient is exhibiting behaviors of feeling excessively joyous, things like dancing or singing or laughing for no apparent reason. And obviously at times it can be inappropriate. To be honest, it doesn't happen too much with our patients. The recommendation is really for the family to avoid putting that patient in a bad position. So teach the families and the caregivers to set the patient up for success. So for example, if the patient likes to laugh or dance, then please make sure that they are not taking the patient to church or funerals or things like movie theaters. Disinhibited behaviors are behaviors that are inappropriate or socially disruptive. So these are the behaviors that the patient may do because many of us might say that they no longer have a filter. Oftentimes, our patients will say hurtful comments to families or caregivers, and these are things that they typically would not have done or said before. Sometimes these behaviors are sexually disinhibited behaviors, such as disrobing in public, exposing their genitalia, or public masturbation. As far as behavioral modifications, try to identify triggers because most of the time they do have triggers. So for example, if the patient has a tendency to use their hands when they're grabbing food, educate the families not to bring the patient to buffet restaurants. Again, they're making these behavioral modifications to set up the patient for success. Another example is if the patient has a tendency to do or say embarrassing things in public. Make sure that the families get one of those companion cards from the Alzheimer Association. And I know we have them, and it says, my companion has dementia and may need extra help and patience. Thank you for your support and understanding. It's about the size of a business card. And if the patient does something that is inappropriate, the family or the caregiver can give this card to whomever is getting upset by the behavior. For sexually disinhibited behaviors, have caregivers wear appropriate clothing, such as scrubs, when they're taking care of the patient. Call the patient by their preferred name and avoid terms of endearment, such as, honey or sweetie. Hiring caregivers who is the opposite sex of the patient's preferred gender is usually pretty helpful in getting these behaviors to stop. I also wanted to make sure to mention, certainly these behaviors can be embarrassing to the families, right? But it's important not to isolate the patient. So instead, bring them to social activities if there are trained caregivers that are conducting the activities. For caregivers, make sure to address their safety and encourage them to call 911 if they are concerned or if they feel like they're in danger for whatever reason, okay? Now, whether the patient lives at home or in a facility, encourage the caregivers to allow the patient privacy. And I will usually gently explain to families that, having sexual urges is a normal part of getting older. And, just to make sure and not to embarrass them and give the patient privacy, take them to their room and give them some space. I'm sure many of you have encountered patients who are irritable with delays, such as medical appointments. So for caregivers, again, have them identify triggers to the irritability. So for example, if a patient is irritable with appointments, teach the caregivers to prepare ahead of time for these appointments. They can do things like preparing medications ahead of time, snacks, know their driving directions, and they need to know where they're going to park. So if the caregivers can identify the trigger, most of the time they're able to develop a plan to kind of work around those triggers. So on this slide are examples of motor disturbances in patients with dementia. Families and caregivers may not always understand the ramifications of falls or dysphagia in the older population. Make sure to teach them fall precautions such as installing night lights, shower handles, make sure that they're securing the rugs with double-sided tape. For patients who are having swallowing problems, you can always provide them education about aspiration precautions, such as changing the patient's consistency of the food, avoiding distraction during meals, and making sure that the patient is sitting upright at a table and that they're supervised during meal times. You can also consider referring them to speech or occupational therapy so that the therapist can help with food prep recommendations. Sleep disturbance is a general umbrella which can include difficulty falling asleep, multiple awakenings, daytime to nighttime reversal, or waking up too early. Like many of the previous behavioral disturbances, the caregiver is probably able to identify several triggers to sleeping problems. A few culprits may include napping in the daytime, caffeine or alcohol intake, lack of physical exercise and social activities, or poor sleep hygiene. So for the caregivers, here are some of the things that you can recommend. First, make sure that they are addressing any medical issues. So things like, pain, anxiety, or depression that is interfering with the patient's sleep. Have them avoid screen time 1 hour before bedtime. And by screen time, I mean, watching TV, scrolling through their phones, or using their tablets to read. During the day, avoid staying in bed and only use the bed for sleeping. Also, when it's time to sleep, make sure that the caregivers are turning off the TV. And instead, they can use white noise sound machines. Regarding the environment, make sure that the caregivers are adjusting the environment so that it is encouraging the patient to sleep. So make sure that it's dark, make sure that the room is cool and it's not too hot, and also that it is quiet and that the noise level is relatively low. What and when the patient eats may also impact their sleep. Avoid heavy meals right before bed. If they want a light snack is okay, but anything heavy should be avoided at least within 2 hours before going to bed, 2 or 3 hours. Avoid alcohol and caffeine. You might have to have the caregivers list the food that they're giving late in the afternoon, and you might have to figure out which one, if any, has any caffeine. Caffeine should not be consumed late in the afternoon. Also, limit fluids after 5 p.m. if it's causing the patient to go to the bathroom often at nighttime. Having a daily routine is extremely crucial in their sleep routine. So have the patient get out of bed the same time every day, even if they didn't sleep well the night before. So usually, again, you want the caregiver to set the patient up for success. So a warm shower or a bath is usually a good option to help them wind their day down. No daytime napping. Also, at nighttime, this is the time right before they're supposed to go to bed. Teach the caregivers that they should be spending the evening doing things that are relaxing with the patient. So things like reading, listening to calm music, or going through some pictures of their families. Don't use the evening time to talk about topics that might cause the patient to worry or get anxious. Patients with dementia experiencing appetite changes can mean either weight loss or weight gain. If the patient is losing weight, have a discussion with the family about their goals of care. So if the patient is losing an excessive amount of weight, does a patient and does a family, do they still want to pursue a thorough medical evaluation? Or do they prefer to keep their loved one comfortable and try more supportive behavioral modifications. Teach the families and caregivers to monitor caloric and portion intake. So one of my questions that I'll ask, so at this time, about how much of a full plate of food is your mother eating? 50%? Okay, let's make a goal of increasing that to 75% and then pushing calorie-dense foods first. If the patient lives alone, it could be something as simple as the patient not getting enough meals throughout the day because they are forgetting, or if the food is just not available for them. If you have a patient who will report, getting full after a few minutes of eating, encourage the caregivers to offer foods that are rich in calories first. So, for example, if they're having toast, tell the caregivers to add some peanut butter or maybe even an avocado to the toast. If they're having pasta, make sure that they are adding some olive oil to the pasta. Okay, so let's go back to Mrs. Johnson, my patient. So I was worried about her wandering. What did we do for Mrs. Johnson? Again, I was worried about her wandering. So was the family. They ended up installing a house alarm, which the caregiver and the daughter are able to monitor remotely, because if you can remember, the daughter lived an hour away. Mrs. Johnson was a very fashionable lady, so the daughter thought that she would probably throw away a clunky GPS tracker. And so instead, she bought her mom an old Apple Watch, which helped her track her mom. Which the patient liked, actually, because she would see pictures of her family flashing on the screen of her watch. Now, much of my initial interventions was teaching Melissa, the daughter, and the paid caregiver about the disease itself, which helped them identify triggers. They identified quite a few triggers for the patient, and they were able to work around those triggers. I had initially suggested counseling for Melissa, but she declined and said that she didn't need it. After a couple of months, she agreed and she started seeing one of our counselors. And I think it's working out well. After a couple months, the family was actually able to hire additional part-time care in the daytime. And we didn't call her a caregiver. We didn't call her a home care aide. We actually called her an assistant for Mrs. Johnson. We thought that she would be more accepting if we called this person an assistant. And the assistant would go on walks with Mrs. Johnson and take her out to errands. Also, by the way, it was during these errands when Mrs. Johnson was out of the house with her caregiver that the original caregiver would perform hygiene care for Mr. Johnson, so that this is one of the triggers that we avoided for Mrs. Johnson's agitation and delusional behavior. Also, it should be noted that to address the agitation, aggression, and anxiety, the daughter and I worked together for over 2 months to increase her sertraline. Oh, my apologies for this slide, but the severity of the NPIQ during the initial intake is 17, not 15. My apologies. So this is a comparison of her NPIQ scores during our first appointment and 3 months afterwards. And certainly you can see here, after 3 months, the behaviors didn't go away, and that's okay. They improved. And we're still, the family, the caregiver, and I are still working on making those behaviors even better, but they improved. And the daughter's distress levels also improved quite a bit because partially, she started counseling, but also, she reported that she felt more empowered because she was learning skills on how to take care of her mother. Okay, now that brings my presentation to an end, but I just wanted to give a quick review of some of the resources that are available to all of you, thanks to the Dementia Care Aware initiative. The Dementia Mini Course is a course that is offered through the Dementia Care Aware website that was produced by UCLA. That's one resource for any of you who want to take it. UCLA, we're also currently running our 4th ECHO session. Now, I think there are 10 different healthcare organizations who are participating in this session, and our previous ECHO course, there was about 14 different organizations. For the current ECHO session that we have, 5 are from California, while the other 5 are from around the nation. The next ECHO session that we have will likely be starting in March 2024. So if you are interested in signing up, please contact our project manager, Jagrup Kaur, which we have our information at the end of these slides. Also, here is a slide on the resources that is available to all of you. The QR codes, if you put it on your phone, again, this is something that you can share with your colleagues, but also with caregivers of your patients. If they put this on their phone, they're able to scroll through all the videos available in English and Spanish, but also there's a few other languages that it's available. The NIH, Caring for a Person with Alzheimer's Disease, that's one of the books that I love. It's a little bit dry, but it's user-friendly for the caregivers. It's easy to understand, and it is free for providers to order from the NIH. The last one that I included in here is the Alzheimer's Association Caregiver Tip Sheets. This is also wonderful. It's user-friendly. They can just print it out, but it is also available in English, Spanish, Tagalog, Chinese, and Japanese. Okay. Now, lastly, but definitely not the least, this is our program. This is the UCLA ADC program. And so for those of you who don't know yet, the ADC program is a co-management model of providing dementia care to patients and caregiver dyads. So as many of you know, CMS recently announced the guide model, which will soon be releasing an RFA in November. So the ADC program, we've been seeing patients since 2012. And the program actually aligns perfectly with the guide model. For those who are interested in adopting the UCLA ADC model of care into their own practice, we typically do charge a fee of $50,000 for 2 years of program support to adopt our program. But thanks to the Dementia Care Aware initiative, there are a few scholarships to disseminate the ADC program into your site if you are a site in California and you are providing care for patients with Medi-Cal. So this means that if you're a provider in California and that you are interested in adopting, your organization would not have to pay the $50,000 fee. So please know that the scholarships through Dementia Care Aware are very limited, and that we have been working with several other organizations that are already ready to start the program implementation. And I think this brings me to the last slide. I'll turn it over to Dr. Rivera.
Thank you, Michelle, for such an amazing and thorough and practical bits of advice. Can you advance to the next slide? And I will wrap this up. Again, we are offering a warm line. Here is the number. You can use the QR code to scan. If we didn't get to any questions today's webinar, feel free to call the warm line and get some personalized advice from one of our many experts. So just want to make you aware, again, there is a warm line for providers and healthcare teams. Next slide. How to claim CE credit. So please complete the evaluation survey using the link in the chat that Rita just placed. We provide free CME and CAMFT credits, so please make sure you click the correct link that corresponds to the type of credit you want. And then upon completing the survey, please scan the QR code or link. That's the other way to do it. Next slide, please. And now we have time, a few minutes for Q&A. And Michelle, I see one question in the chat and the Q&A section. What would you recommend for a patient who has an increased appetite and will eat a week's worth of food in one day?
That is a tough one. That's a tough one. I think for this one, I certainly wouldn't say that it's uncommon. It does happen. And I'm hoping that that particular patient has caregivers at home, because it's really going to be up to them to make sure that that patient is not able to access and eat all of that food. I think a lot of that behavior too, it might stem from the patient not having enough activities to do, whether it's like physical activities or social activities. So it could be that the patient is eating out of boredom. And so the solution to that would be, if it's appropriate, to put them in some kind of a program like an adult daycare, where they are certainly able to control those behaviors, or have the families bring the patient to a senior center activity, which again is another distraction and another activity to get them out of the house so that they don't have access to all the food.
Online can also include both pharmacologic and non-pharmacologic recommendations. Of course, it's not a formal consultation. We can't take any specific patient information, but we can provide general guidance. So I want to thank you again, Michelle, for an amazing presentation and for your time and for sharing your expertise, especially through the case study, which I felt was really helpful to hear. And on behalf of everyone at Dementia Care Aware, we thank you. And again, you can find the recording on the slides on our website. Thanks so much, everyone. Take care.
Thank you. Take care.